Welcome to Neurological Assessment. The objectives for today's lesson will be based on the QCC framework. Objectives based on the QCC framework. Assessment. Identify basic neurological assessment. Communication. Utilize SBAR format and information technology to support and communicate a plan of care for the client with neurological changes. Caring interventions. Identify nursing care for clients with neurological or sensory deficits. Clinical decision making. Identify and discuss nursing priorities appropriate for the client with neurological or sensory deficits. Teaching learning. Identify appropriate teaching priorities for the client and family with neurological deficits. Further objectives include collaboration. Identify and collaborate with members of the healthcare team to provide resources for the client with neurological deficits. Managing care. Identify management of the client with neurological deficits, considering financial reimbursements. First, let's think about the function of the nervous system. It controls all of the following functions: motor, sensory, autonomic, cognitive, behavioral activities. Some important structures of the neurological system include the central nervous system, which includes the brain and the spinal cord, versus the peripheral nervous system, which includes the cranial and spinal nerves, autonomic and somatic systems. Basic functional unit of the neurological system is the neuron. This is a picture of a neuron. See all of its parts: the dendrites, nucleus, axon, the node. The myelin sheath is going to become very important when we discuss multiple sclerosis a little bit later on in the semester, and the synaptic terminals. This is a real-time picture of how the neurons look in our body. This is a picture of the brain. Review the anatomy and physiology. This is a picture of the topography of the cortex as it relates to function, which is far more important for us when we care for patients who have neurological deficits. Notice the areas where written speech is prominent: motor speech, auditory, visual, and compare them to your previous picture of the frontal lobe, occipital lobe, and so forth, and see if you could put together what areas relate to what function. This is another picture putting together the anatomy and the physiology and the function in a different view. Cerebrum, two hemispheres, right and left, connected by the corpus callosum, controls the ability to think and reason. 4 lobes: frontal lobe, parietal lobe, temporal lobe, occipital lobe. Think about what areas of function are controlled by the different lobes. Cerebrum, frontal lobe, the largest lobe, controls the ability to think and reason, controls speech, word formation, personality, motor function of voluntary muscles, concentration, problem solving, memory, abstract thought, affect and mood, judgment and inhibitions. Think about if a patient has a stroke or trauma in this area, all of these functions will be affected. Cerebrum, parietal lobe, sensory area, proprioception, interpretation and awareness of body position in relation to space, discrimination of sensory impulses for pain, touch, and temperature for all senses except smell, sensory speech center. Again, think about if there's trauma to this area, what limitations of function will the patient experience? Cerebrum, temporal lobe. This area integrates visual and auditory area. This is where sound is interpreted. This is where the understanding of the spoken word originates, and sensation of taste and smell. So if a patient has trauma to this area, these are the functions that will be affected. Cerebrum, occipital area. This is where visual recognition and focus of the eye occurs, understanding of the written word. So again, injury to this area, the patient will have impairment to vision. The interbrain or middle fossa. Thalamus, a relay station for sensory impulses. Hypothalamus controls regulatory function, including temperature, pituitary hormone production, and water balance. The pituitary gland, the most important gland in the body. Master gland controls all endocrine functions. Pituitary hormones secretion controlled by the hypothalamus. Fluid balance controlled by the hypothalamus and the pituitary. Brainstem lies below the diencephalon and contains cranial nerve 3 through 12. The brainstem controls the heart rate and rate of breathing, includes the midbrain pons and medulla, and connections for cranial nerves. If there is a herniation of the brainstem, the patient will most likely end up on a ventilator as a result of that injury. The cerebellum, the lesser brain, separated by the tentorium, helps maintain equilibrium and balance, muscle control and coordination, contains motor and sensory pathways that affect balance. Arterial blood supply of the brain. The brain has high metabolic demand and requires high blood flow. In fact, it receives 15% of cardiac output per minute. If there is poor collateral blood flow, the brain does not tolerate decreases or changes in blood flow well, and in fact, irreversible tissue damage can occur when vessels are occluded. During a stroke, one of the arteries listed in this slide can be affected. Meninges, 3 layers of connective tissue that surround the brain and the spinal cord. The dura mater is the toughest outermost layer, arachnoid matter, and middle layer, subarachnoid space, a common area for bleeds to occur. Pia mater, innermost layer, attached to the brain and spinal cord. Blood supply and oxygen occurs here. This is a mnemonic to help you remember the cranial nerves. On old Olympus, towering tops of Finn and German viewed some hops. Olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, acoustic, glossopharyngeal, vagus nerve, spinal, and hypoglossal. Continuing with cranial nerve assessment, cranial nerve 5, trigeminal nerve, sensory innervation of face, forehead, cheek, and chin, corneal reflex, motor innervation of temporal and masseter muscles, cranial nerve 7, facial nerve, sensory innervation of tongue, motor innervation to facial muscles, is evaluated by having the patient smile, frown, open eyes wide, raise eyebrows, and wrinkle forehead. This is the nerve that is affected when a patient develops Bell's palsy. Cranial nerve assessment. Cranial nerve number 5, trigeminal, sensory innervation of the face. Check the forehead, cheek, and chin and corneal reflex. Motor innervation of the temporal and masseter muscles. Cranial nerve number 7, the facial nerve, sensory innervation of the tongue. Motor innervation to the facial muscles. Checking by smile, frown, open eyes, raise eyebrows, and wrinkle forehead. This is the nerve that's affected when Bell's palsy is diagnosed in a patient. Neurotransmitters. Neurotransmitters communicate messages from one neuron to another or to a specific target tissue. Neurotransmitters can potentiate, terminate, or modulate a specific action or can excite or inhibit a target cell. Many neurologic disorders are due to an imbalance in neurotransmitters. Autonomic nervous system functions to regulate activities of internal organs and to maintain and restore internal homeostasis. Sympathetic nervous system, flight or fight response. The main neurotransmitter is norepinephrine. Parasympathetic nervous system controls mostly visceral functions, regulated by centers in the spinal cord, brainstem, and hypothalamus. Neurologic assessment. What is its main purpose? To detect the presence of neurological disease or injury, monitor its progression, and determine the type of care that is needed. Most important of neurological assessment is level of consciousness. Reduced level of consciousness can indicate a worsening clinical picture requiring immediate assessment and intervention. What are the important areas we want to focus on during our history taking in reference to a neurological assessment? Does the patient have pain, seizures, dizziness, which is an abnormal sensation of imbalance or movement, vertigo, the illusion of movement, usually rotation, visual disturbances, weakness, abnormal sensations? Levels of consciousness: alert, follows commands, responds appropriately; lethargic, is drowsy, has delayed responses to verbal stimuli; stuporous, requires rigorous stimulation for a response; comatose, does not respond appropriately to verbal or painful stimuli. Question: tell whether the following statement is true or false. The earliest sign of increasing intracranial pressure is a change in level of consciousness. Think about the answer. Your initial neurological assessment should be comprehensive, including vital signs. Focus on level of consciousness and mentation, checking for cranial nerves, checking if the pupils are equal, round, and reactive to light and accommodation, checking movement, sensation, cerebellar function, and reflexes. Purpose is to establish a baseline. Assessment frequency. Bedside assessment is done at the beginning of the shift and possibly Q15 minutes if we are very concerned about the patient. Q30 minutes, Q1 hour, or Q2 hours. The focus is on part of the nervous system affected by the patient's condition. Some important assessment questions. Checking the mental status. Is the patient A&O times 3? If not, can they be aroused and respond appropriately? Are they lethargic? Response is slow and hesitant, may be restless or listless. Are they in a stupor? Aroused only with vigorous or continual stimulation? Do they only respond to pain? Are they in semicoma? Are they in a coma? Unresponsive to all stimuli, that's what that means. Are they obtunded, requiring increasing sensory input to produce a response or output? Assessment for tremors or abnormal movement is also important during the assessment questioning period. Glasgow Coma Scale, the most used scale, not necessarily the best scale, but the one that is most frequently used in varying institutions. The patient receives a score for the best response from 1 to 5 in each of 3 areas: the best eye opening, motor response, and verbal response. The 3 scores are added together, a total from 3 to 15. The higher the score, the better. A score of below 8 usually means the patient will need to be on a ventilator. A more focused cranial nerve assessment would include 4 key cranial nerves: cranial nerve 2, optic, visual acuity and gross visual fields; cranial nerve 3, oculomotor, pupillary constriction, checking if the pupils are equal, round, and reactive to light and accommodation; cranial nerve 4, trochlear, down and in eye movements; cranial nerve 6, abducens, checking for lateral eye movements. Check these together. Check for nystagmus and paralysis. Further assessment would include checking for mood. Is the patient euphoric, depressed, irritable, rageful, tense, hyperactive, or labile? How is the memory? Is it loose? Do they remember recent events or past events? Thought. Is it spontaneous, natural, or clear? Or is it incongruous, distorted? Are there bizarre associations, delusions, hallucinations? Further assessment would include evaluating speech patterns. Is the patient articulate? Does the patient have slurred or inappropriate words? Is the patient aphasic, particularly expressive aphasia, which means the absence or impairment of ability to verbalize or write either completely or incompletely? Does the patient exhibit dysarthria, difficult effective speech, which is related to tongue and muscle impairment, most often caused by a stroke? Aphasia is a disorder caused by injury to the cerebral cortex. Expressive or Broca's aphasia is impaired fluency, difficulty finding words. Receptive or Wernicke's aphasia is inability to understand written words or speech. Global aphasia refers to the lack of both expressive and receptive ability. Other aspects of assessment would be to evaluate the patient for posturing. Decorticate posturing is posturing towards the body. Decerebrate posturing is posturing away from the body. Flaccid means that there is no muscle tone whatsoever and is actually the worst prognosis. Further considerations during the assessment process would include gerontological considerations. It is important to distinguish normal aging from abnormal changes. Determine previous mental status for comparison. Assess mental status carefully to distinguish delirium from dementia. Normal changes may include losses in strength and agility, changes in gait, posture, and balance, slowed reaction times and decreased reflexes, visual and hearing alterations, decreased sense of taste and smell, dulling of tactile sensation, changes in the perception of pain, and decreased thermoregulatory ability. This is just a picture showing techniques to elicit major reflexes, most often done by physicians, although if you work on a neurological unit, you might be doing some of this as a bedside nurse. This is a picture of a stick figure commonly used to record muscle strength. Recording muscle strength as follows: 5. Full range of motion against gravity and resistance. 4. Full range of motions against gravity and moderate amount of resistance. 3. Full range of motion against gravity only. 2. Full range of motion when gravity is eliminated. 1. A weak muscle contraction when palpated but no movement. 0. Complete paralysis. This is a picture of a pronated drip. The test is positive if the client is unable to hold their arms up. This is a sign of a deficit. This is a neurological abnormality. Normally, you should be able to hold your arms up. This is a picture of Romberg's sign. To test Romberg's sign, test standing with feet together. It is a positive test when swaying or toppling over occurs with eyes closed. This is a sign of a neurological deficit. Dyskinesia, a deficit in voluntary movement. Testing for alteration in sensation is part of a neurological exam. We test light touch with wisps of cotton. We test superficial pain with pinpricks from sharp objects. Discrimination varies with parts of the body touched simultaneously with two sharp objects. This is how you figure out where the areas of sensation are diminished. You must test simultaneously. Further abnormal assessment findings include nuchal rigidity, Brzezinski's sign, and Kernig's sign. Sensory examination might show paresthesias, temperature changes, dermatome changes, proprioception changes, stereogenesis, and vibration changes. Further assessment of meningeal irritation would include testing for Kernig's sign and Brzezinski's sign. Meningeal irritation is an abnormal neurological finding. Kernig's sign: with the patient supine, flex one of her legs at the hip and knee to create a 90-degree angle. Then straighten it. Pain or resistance equals meningeal irritation. Brzezinski's sign: with the patient supine, place your hands behind his neck and flex it forward. If he responds by flexing his knees, he probably has meningeal irritation. Again, an abnormal neurological finding. Babinski reflex: abnormal neurological response in adults, but not abnormal in infants. It is tested by stroking the lateral aspect of the sole from the heel to the ball, curving medially across the ball. Use the lightest touch stimulus that produces a response. Normal movement of the toes is flexion. Dorsiflexion of the great toe with fanning of the other toes equal upper motor neuron disease. It is a very important abnormality to test for. Doll's eyes. Another neurological assessment that could be abnormal. You're testing for oculocephalic reflex response. Normal response is when the head is rotated and the eyes turn together to the side opposite to the head movement. This is an example of a neurological flow sheet in a critical care unit. This varies from hospital to hospital and is now online. Again, another example of the neurological flow sheet, the second half. Further diagnostic evaluation is done by a CAT scan. CAT scans show a cross-sectional view of the brain. Abnormalities show up as variations in tissue density. First, CAT scans are done without IV contrast generally, and then follow-up CAT scans are done with IV contrast. Other radiological tests include a PET scan. Positron emission tomography produces images of actual organ function. Use of radioactive substances permit measurements of blood flow and tissue composition and brain metabolism. Helpful to look for metastasis of cancer or possibly even new cancers. MRIs, magnetic resonance imaging. Use of magnets identifies cerebral abnormalities. MRAs, magnetic resonance angiography, allows for visualization of the cerebral vasculature without dye. Best for non-acute conditions, as it can take up to an hour to get a complete evaluation. Cerebral angiography uses contrast agent to study cerebral circulation. Digital subtraction angiography, a specific type of cerebral angiography. X-ray images taken before and after an injection of a contrast agent for comparison of the carotid and vertebral arterial system. Think about the considerations for patients receiving dye. EEG, electroencephalogram, records electrical activity in the brain, used to diagnose timing, severity, and length of seizures, and also can be used to diagnose brain death if there is a lack of electrical activity. Further radiological tests include carotid Dopplers. Carotid Dopplers test for the flow of the carotid arteries and help the practitioner to assess for blockages, narrowing, or stenosis of the carotids, which can put the patient at risk for a stroke. EMG, testing the electrical potential of the muscles, useful to diagnose neurological abnormalities that will affect the muscles. Quick contestant test the jugular veins are compressed during the spinal tap to check for CSF changes. Another diagnostic test includes lumbar puncture. A lumbar puncture spinal tap needle is inserted into the subarachnoid space between the third, fourth, or the fourth and fifth lumbar vertebrae to withdraw cerebral spinal fluid in order to measure and reduce pressure, examine for blood, and detect abnormalities, and to administer antibiotics. May cause brain herniation, which is the brain shifting downward, which is a severe complication. The fluid from a lumbar puncture should be clear. If there is blood in the fluid, it could possibly mean a traumatic stick or bleeding into the cerebral spinal fluid from another injury. This is a picture of a little cartoon talking about spinal fluid analysis or cerebral spinal fluid analysis. The spinal fluid is brought to you from the cerebral spinal sac. What will you look for? We'll look for the color to be clear, as mentioned earlier. The pressure should be less than 20 centimeters of water, protein 15 to 45 milligrams per deciliter, glucose 50 to 75 milligrams per deciliter, minimal white blood cells. There should be no bacteria. If there is, this is a sign of meningitis. Keep client in prone position for 4 to 8 hours after the procedure. You may turn from side to side. Encourage fluids. Check for headache, which is a common side effect of a lumbar puncture, and leakage at the puncture site. CSF leakage can be a complication. Notify doctor for leakage of clear fluid at puncture site. Brain death. To diagnose brain death, some parameters need to be evaluated. First off, we need to know the nature of the coma. There is no evidence of cerebral or brainstem function times 6 to 24 hours per an EEG. Normal body temperature. There are no depressants, drugs, or alcohol on board with the patient. Complete unresponsiveness. Absent motor and reflex, corneal and ocular movements. Pupils are fixed and dilated. The patient is apneic. Lack of cerebral circulation. If the patient is apneic, they obviously can be ventilated by a mechanical ventilator but still have no brain function. Just a question. Which of the following diagnostics is frequently performed prior to a craniotomy to assess the patency and adequacy of cerebral circulation? Lumbar puncture, myelography, cerebral angiography, or electrical encephalography? Think about the answer. Please complete these true-false questions on your own based on the previous lecture content. Please complete the fill-in-the-blank questions below, which are based on the previous lecture. Please review this case on your own. This completes the neuro assessment lecture.